This is an article I recently came across entitled High Load Strength Training Improves Outcome in Patients with Plantar Fasciitis, a randomized controlled trial with 12-month follow-up. This was conducted by Rathliff and colleagues and appeared in the Scandinavian Journal of Medicine and Science and Sports. As we all know, plantar fasciitis is a debilitating condition, and it's the most commonly reported cause of inferior heel pain. It's characterized by pain at the calcaneal origin of the plantar fascia, as well as increased thickness of the plantar fascia. Its prevalence has been estimated to range from 3.6 to 7% and has been shown to account for up to 8% of all running-related injuries. Results from randomized controlled trials suggest that plantar fascia-specific stretching, as well as shoe inserts, are effective in the treatment of plantar fasciitis. However, approximately 40% of patients continue to have symptoms and pain 2 years after the initial diagnosis. High-load strength training that causes high tensile loads across the tendon has yielded promising results on degenerative tendon disorders such as Achilles and patellar tendinopathy, and may have promising results when it comes to plantar fasciitis. However, the clinical effect from high-load strength training seems to take time before it manifests, and therefore studies often use 3 months as a primary endpoint. One possible option to induce controlled high-load tensile forces across the plantar fascia is through the combined use of Achilles tendon loading and the windlass mechanism. The windlass mechanism causes tightening of the plantar fascia during dorsiflexion of the MTP joints. Additionally, the close anatomical connection between the Achilles tendon, paratendon, and the plantar fascia suggests that high loading of the Achilles tendon is indeed transferred to the plantar fascia. Collectively, this information suggests that high loading of the Achilles tendon combined with activation of the windlass mechanism may cause high tensile loads across the plantar fascia. This may be achieved by performing a simple unilateral heel raise combined with dorsiflexion of the MTP joints. The purpose of this study was therefore to investigate the effectiveness of shoe inserts and plantar fascia-specific stretching versus shoe inserts in high-load strength training consisting of unilateral heel raises and dorsiflexion of the MTP joints in patients with plantar fasciitis. It was hypothesized that patients randomized to shoe inserts in high-load strength training would have a larger improvement in foot function index from baseline to the primary endpoint at 3 months compared with patients randomized to shoe inserts in plantar-specific stretching. The study was a randomized controlled trial. To be included in the study, subjects had to have a history of inferior heel pain for at least 3 months, pain upon palpation of the medial calcaneal tubercle or the proximal plantar fascia, as well as thickness of the plantar fascia of 4 millimeters or greater. Exclusion criteria involve the following: less than 18 years of age, a history of systemic diseases, prior heel surgery, pregnant, or a corticosteroid injection for plantar fasciitis within the previous 6 months. With regards to randomization, 48 patients with ultrasonography verified plantar fasciitis were block randomized to shoe inserts and daily plantar-specific stretching, which comprised a stretch group, or shoe inserts in high-load strength training every second day. This was a strength group using a computer-generated sequence created by the main investigator in blocks of 6. Both groups received a short patient information sheet as well as gel heel inserts. The patient information sheet covered information on plantar fasciitis related to advice on pain management, information on how to modify physical activity, how to gradually return to sports, as well as information on how to use the gel inserts. The stretching protocol was identical to that of D. Giovanni et al. In 2003. Patients were specifically instructed to perform this exercise while sitting by crossing the affected leg over the contralateral leg. Then, while using the hand of the affected side, they were instructed to place the fingers across the base of the toes on the bottom of the foot and pull the toes back toward the shin until they felt a stretch in the arch of the foot. This provides a video demonstration of the stretch technique used in the study. Patients were instructed to perform the stretch 10 times for 10 seconds, 3 times per day. For the high-load strength training group, high-load strength training consisted of unilateral heel raises with a towel inserted under the toes to further activate the windlass mechanism. This provides video demonstration of the unilateral heel raise. Subjects were instructed to perform a 3-second concentric contraction, 2-second isometric hold, and 3-second eccentric contraction. It should be mentioned that the towel was individualized, ensuring that the patients had their toes maximally dorsiflexed at the top of the heel raise. For the strength group, patients were instructed to perform the exercises every second day for 3 months. Again, every heel rise consisted of a 3-second concentric phase and a 3-second eccentric phase with a 2-second isometric phase at the top of the range. The high-load strength training group was slowly progressed throughout the trial, as previously reported by Kongsgaard et al. They started at a 12-rep max for 3 sets, with 12-rep max being defined as the maximal amount of weight that the patient can lift 12 times through the full range of motion while maintaining proper form. After 2 weeks, they increased the load by using a backpack with books and reduced the number of reps to 10, simultaneously increasing the number of sets to 4. After 4 weeks, they were instructed to perform 8 repetition max and then perform 5 sets. They were instructed to keep adding books to the backpack as they became stronger. In the case of bilateral plantar fascia pain, subjects were instructed to perform the high-load strength training with both limbs. At 1-month follow-up, the patients were then again seen by the MD as well as a physical therapist. The MD performed ultrasonographic measurement of the thickness of the plantar fascia, while the PT assessed how the plantar-specific stretching or high-load strength training was performed to ensure proper form and technique. The primary outcome was defined a priori and consisted of the change in total foot function index from baseline to 3-month follow-up. The foot function index is a self-report questionnaire that assesses multiple dimensions of the foot. It consists of 23 items divided into 3 subscales that quantify the impact of foot pathology on pain, disability, and activity limitations. The scores range from 0 to 230, with 0 reflecting no pain, disability, or activity limitation. The minimal important change is 7 points for the total scale. Self-report questionnaires were filled in by patients at baseline, as well as at 1, 3, 6, and 12 months after inclusion in the study. Secondary outcomes of interest included the thickness of the plantar fascia, item 1 in the foot function index, which is foot pain at worst, item 2, which is foot pain during the first step in the morning, satisfaction with the result of the treatment, physical activity level measured as sports participation, and average leisure sports participation per week. Ultrasonographic measurements were made at baseline as well as at 1, 3, and 6 months. The same rater performed all measurements. Ultrasonographic measurements were carried out using a previously described method with substantial reliability. All analyses took place after the 12-month follow-up, and no intermediate analyses were performed. Between group comparisons were analyzed on an intention-to-treat basis. The primary outcome was analyzed using linear regression with adjustment for baseline scores. This was carried out using the outcome, foot function index, as a dependent variable with group and baseline data as independent variables. Secondary outcomes were also analyzed using linear regression with adjustment for baseline values, except leisure physical activity, which was analyzed using Poisson regression with adjustment for baseline leisure time physical activity. 48 patients were included and 24 were randomized to plantar-specific stretching and 24 patients to high-load strength training. Follow-up ranged from 77 to 94%, with an 81% follow-up at the primary endpoint at 3 months. At the primary endpoint at 3 months, the strength group had a foot function index that was significant and 29 points lower compared with the stretch group. At 1, 6, and 12 months, however, there was a non-significant 5 to 7 point difference in the foot function index between groups. At 12 months, the total foot function index score was 22 points in the strength group and 16 points in the stretch group. Patients randomized to high-load strength training reported significantly less worse foot pain at the primary endpoint at 3 months. Otherwise, no significant differences existed between groups, but patients randomized to high-load strength training tended to be more satisfied with the result of the treatment at 3 and 12 months. This study is unique in that it's the first randomized trial to compare high-load strength training with plantar-specific stretching among patients with ultrasonography-verified plantar fasciitis. The primary endpoint at 3 months showed that high-load strength training was associated with a larger improvement in foot function index and that patients tended to be more satisfied with the results of the treatment. So why was high-load strength training associated with a larger improvement compared with plantar-specific stretching after 3 months? Perhaps it's a function of large tensile forces, which have been associated with improvements in symptoms in other conditions involving degenerative changes, as seen in plantar fasciitis. Furthermore, the plantar fascia is made up of type 1 collagen fibers, which respond to high load through increased collagen synthesis. As patients with plantar fasciitis show degenerative changes at the plantar fascia enthesis, increased collagen synthesis may help normalize tendon structure and improve patient outcomes. It's important to highlight that the high-load strength training was not associated with larger reduction in the thickness of the plantar fascia and at follow-up compared with those allocated to plantar-specific stretching. Both groups also had a significant reduction in the thickness of the plantar fascia, but the majority of patients still had significant thickening of the plantar fascia compared with a level of approximately 2.2 to 4 millimeters observed in pain-free individuals. This may point toward that some abnormalities within the fascia may still persist even though symptoms have decreased. This is similar to what's known as the iceberg theory, with pain being just the tip of the iceberg. With regards to study limitations, no data were obtained on adherence to exercises or the quality of the home-based exercises. Therefore, we don't know how often or for how long patients perform their exercises in either group. High-load strength training was not associated with better long-term outcomes at 12 months, but only with a better short-term effect after 3 months. This may very well be attributed to patient compliance within the intervention. We suspect that patients at some point will stop performing their exercises when they reach a pain level that is satisfactory to them. Valid data on long-term compliance would answer this question. The major takeaway from this study is that a simple program consisting of high-load strength training performed every second day results in a superior outcome at 3 months compared with plantar-specific stretching and may aid in a quicker reduction in pain and improvements in function. However, there are no significant benefits of high-load strength training at the secondary endpoints at 1, 6, and 12 months.